Okay, good morning everyone. Thank you for spending part of your Saturday with us. So I think I know most of you and hopefully you all know me as well, but just to be formal, I'm Reshma Mahtani. I'm Chief of Breast Medical Oncology at Miami Cancer Institute. I used to be at the University of Miami for many years, and good to see many of my friends and colleagues here as well today. So just starting out, I'd like to kind of give some background on the program. COEDS used to stand for the Community Oncology Education Dinner Series. We've changed the D to Discussion Series, as we're clearly not at dinner this evening. But the program was really intended years ago to come together as a group in the community. We all share patients, we all have clinical trials that we have at our institutions, and it was really meant to be a collaborative session, kind of informal, and it grew. And it grew because the team at Total Health took it over, and they make everything bigger and better, and they make you feel like you're at a wedding with beautiful flowers and wonderful snacks. You will be fed and overfed today, I guarantee you. So thank you to the team at Total Health as always. You may notice I'm not Dr. Lauren Karkas. She was supposed to be joining us this morning and actually chairing the program today. Unfortunately, Lauren is ill, but she sends her good wishes and our good wishes to her for a speedy recovery. Okay, so before we start the session, I'd like to invite Raquel to talk to us about some housekeeping items.
Good morning, everyone. I very quickly wanted to review a few items before we get started. So in front of your table, you'll find an agenda and notepads. It includes the Wi-Fi information, non-CME sessions, and CME informations. If you download the app, it has all that information as well. And my team will be at the front desk. If you have any questions or need any help, someone will be there all day. Thank you.
Okay, thanks, Raquel. All right, so now our panelists are already on the stage, but I'd like you to just briefly introduce yourself. So Dr. Dempsey, I'll start with you.
Hi, my name's Naomi Dempsey. I'm a breast medical oncologist at the Miami Cancer Institute, and I practice in our Plantation location.
Hi, I'm Dr. Star Mountner. I'm a breast surgical oncologist at the Miami Cancer Institute, and I practice in Miami.
Good morning, everyone. My name is Yusuf Zaidan. I'm a radiation oncologist at the Lynn Cancer Institute in Boca, and I'm part of Baptist Health.
Good morning, everyone. My name is Maria Rueda Lara. I'm a psychiatrist, and I'm trained as a psycho-oncologist, and I only work with cancer patients, and I work at Sylvester Comprehensive Cancer Center, the University of Miami.
Good morning. My name is Debbie Denardi. I'm a breast cancer survivor, and I also carry a BRCA mutation, and I'm here to share my patient perspective.
Great, thank you all. So the first session is actually a case. The case has been engineered, and as we discussed issues that come up within the context of this case, we will be going through data. We do have a dedicated session at the end of the day for questions and answers, but if you all have a burning question that you want to ask, feel free to. As we're able to keep on time, we'll take a few questions peppered in. So let's start with a case, a premenopausal woman with ER positive, HER2 negative breast cancer. So this is a young woman, she's 37 years old, premenopausal, and she feels a mass in her left breast, and she presents to her gynecologist. Imaging is done, and it shows a suspicious finding as well as suspicious left axillary lymph node, and the mass is biopsied, invasive ductal carcinoma, grade 2, hormone receptor positive, HER2 1+, Ki67 15%, and the lymph node is also biopsied and confirms lymph node involvement. So staging studies are done. There is no evidence of distant metastasis. Social history, she's married, she works as a social worker, and she has a family history of a maternal aunt with postmenopausal breast cancer at age 56. So many of these patients, after an initial diagnosis, end up seeing a breast surgeon first. So Star, I'll ask you to kind of talk to us about your approach when you see a newly diagnosed patient, and what are the surgical issues that come to mind?
Sure. So in seeing a patient like this, I think very importantly, we note that she's premenopausal, melliferous, and is 37 years old. So those are very important considerations, and obviously she is also lymph node positive. And so we want to consider what the first step in treatment will be for her and what type of toxicities that type of treatment may have for her and repercussions down the line. In a young woman, even though she is ER positive and HER2 negative, due to her axillary lymph node involvement, I would strongly consider neoadjuvant chemotherapy prior to surgery in order to attempt to downstage her axilla. She also has a large breast mass, and everything is considered in relation to breast size. But if she is not a candidate currently for breast conserving surgery and desires breast conserving surgery, another reason to consider neoadjuvant chemotherapy is to attempt to shrink the mass within the breast tissue so that she could potentially become a candidate for breast conservation. It's well known that younger women will often choose mastectomy over breast conservation, but it is an option for them. In this particular case, I think the strongest consideration for neoadjuvant chemo is to try to downstage her axilla. There was a large study looking at premenopausal breast cancer patients, and across all tumor subtypes, about 52% of women under the age of 40 were able to downstage their axilla. And so we're really trying to avoid axillary dissection in this young woman because it will increase her risk of lymphedema and morbidity. And if we can downstage her to become a sentinel lymph node biopsy candidate, that would be great for her. We also want to refer her to genetic counseling. She's very young and she does have a family history. I tell patients that only about 10% of patients will ultimately test positive for an actionable genetic mutation after being diagnosed with breast cancer, but it's still an important consideration, especially in a 37-year-old with breast cancer. And then lastly, she is nulliparous, and if she desires children in the future, chemotherapy and tamoxifen or endocrine therapy can definitely affect her chances for conceiving, and we're also going to want her to delay trying to conceive in the future. And so a referral to an oncofertility specialist is something that's important as well, and you want to place that referral as soon as possible, as the patient would like to probably start treatment within the next several weeks, and the process of preserving eggs can be somewhat of a lengthy one. And so we try to get those patients in immediately to oncofertility to talk about egg preservation.
So another issue that comes up with regards to imaging, this woman is young, and we know that younger women tend to have denser breast tissue. So as we're considering offering this woman neoadjuvant therapy, what are your views on doing an MRI in this situation?
So I think MRI is clinically warranted in this situation. I will not order an MRI for every single patient that's diagnosed with breast cancer, and I kind of choose on an individual basis who I think needs an MRI, but this woman meets criteria. She's young, she may be a genetic mutation carrier, she has dense breast tissue, probably given that she's 37 years old, and we're going to be giving her neoadjuvant chemotherapy, and there's a possibility that she may choose breast conserving surgery in the future. So with that MRI, what you're really looking for is to rule out multifocal or multicentric disease. If she has another focus of cancer within that breast, it may show that she's actually not a candidate for breast conserving surgery. Let's say that focuses in an entirely different quadrant from the index cancer. Additionally, we will sometimes find contralateral findings or findings on the other breast at the time of MRI. Now, most of the time, the workup of those findings shows benign results, and it may be a false positive finding given that MRI is so sensitive, but sometimes we actually pick up a second cancer on that other breast. And so I think it would be very important. I'm also interested in seeing what is her lymph node burden of disease. Is it one lymph node that looks like it's maybe abnormal on MRI, or are there multiple lymph nodes, bulky adenopathy? Is this going to be someone who potentially has more locally advanced disease than what meets the eye based on her mammogram and ultrasound? So I would definitely order an MRI in this case, and I would plan, if she is getting neoadjuvant chemotherapy, to repeat that MRI at the completion of neoadjuvant chemotherapy to see her radiologic response to therapy, especially if she's choosing breast conserving surgery. That's important.
Thanks for those comments. So in this case, the patient does undergo a breast MRI. There are no additional concerning findings in the contralateral breast. And in terms of the size of the index tumor, it is a T3, clinical T3 lesion over 5 centimeters, and 3 axillary lymph nodes look suspicious. And then, as you pointed out, the need for genetic testing, that testing is done, and it reveals a pathogenic mutation in ATM. So Debbie, I'm going to ask you to kind of give us your perspective. You talked about your own personal history, and maybe you can also take this moment to talk to us about FORCE, the organization, and what the objectives and the goals of the organization are.
Yes, what I wanted to share with you is that when I was diagnosed in 2010, the only thing they tested is for BRCA1 and BRCA2. That was all what it was in the hereditary cancer landscape. Now there are so many new mutations that they need to be addressed because there are different ways to approach the patient and just how to recommend treatment for them. So I think in the next slide there is This is what I wanted to go over with you. Before, it was less than 5% of hereditary cancers were related to breast cancer. But right now we have that from the complete landscape, 10% of those patients are diagnosed with a hereditary mutation. And that is very important because we have different types of screening, different types of recommendations for their treatment. So what I wanted to concentrate in that is the 10%, not every cancer is hereditary, but 10% of that, and it's growing because as we are discovering more different types of mutations, more patients are included in this hereditary cancer landscape. In the next slide, what I wanted to show here is the lifetime risk, because we always talk about the 1 in 8 women will develop breast cancer. That is the first line, where women do not carry a mutation. That is 12 to 13%. But if you look at the following lines, when a woman carries a mutation, ATM, BRCA1, BRCA2, we have that their increased lifetime risk is between 40 to almost 65%. And that does not decrease as they grow older. So this is very important that is 4 to 5 times more than the general population. That's why it's very important to share this information with the patients so they can take care of future screenings. And in the next one, I'm going to talk a little about genetic testing, because this is really very important, because we need to offer genetic counseling. We need to tell the patient, this is what we're going to do. These are the implications for you and your family, because it's not just a personal thing. If you're diagnosed with a genetic mutation, that involves all your family, your kids, your siblings, even sometimes your parents, that you need to provide this information so they can get tested also, because the screening is going to be different, like the guideline says. That the screening is going to be, for example, for a breast cancer, for a BRCA1 mutation, it says that you need to be screened now with a mammogram and ultrasound, in 6 months with an MRI, again in 6 months a mammogram and ultrasound. So the screenings are more frequent, and also the recommendations are different. If a patient wants to do a prophylactic double mastectomy, that is offered to the patient. If they want to go through the hysterectomy. So really those are the recommendations that they're discussed with the patients when the report comes back. But this is very important for you to remember when you're discussing this before doing genetic testing, is that is the insurance coverage. Because after you are tested for a genetic mutation, life insurance and long-term care, it cannot be secure after you test positive for a mutation. So that is really something important that you need to discuss with the patient. So before doing the genetic test, they can secure this type of insurance if they want. Because suppose there is a very young patient and test positive for a mutation, and then they develop cancer and they pass away, they are not leaving life insurance or long-term care for their kids. So those are the things that we need to discuss with the patients, and that is very useful information for our decision making.
Thank you so much. And you brought up a lot of the issues that are important. One of the factors that we see with a patient with a new diagnosis is this feeling of being overwhelmed, right? And they're worried about what is going to happen to them individually in terms of surgical options. Do they need chemotherapy? What are those treatments going to look like? And when we bring up this aspect of genetic testing, sometimes there's a little bit of a disconnect about how is this going to impact me and how am I going to handle a genetic syndrome in terms of, family relationships and things. So Maria, I think these were, the next few were your slides that you wanted to take us through some of the psychosocial aspects of genetic testing.
It's kind of like focusing more on the human side of cancer. These women learned that she has cancer, she's already overwhelmed, but now she was told, okay, you have to do genetic testing. Even though it's only 10% risk that she will carry a mutation, she's probably not listening to this. She's already thinking whether she will develop ovarian cancer, if she's gonna pass that to her family, what are the insurance implications. So all of this can generate anxiety, anger, depression, or guilt. And you said something extremely important. Patients need to learn about this, and I will focus more about that So there are risk factors for psychosocial distress. So researchers have done research in this area, and patients who are at risk of being distressed from genetic counselor are patients who are younger age, being unmarried, lower socioeconomic status because this is expensive and insurances do not cover that, having children, recent diagnosis, recent history of breast symptoms, past experience of cancer, and its impact on the family. So if the mother died of cancer, they're gonna remember that. Also being the first one tested in the family, when they're like low level of family cohesion, if they're like siblings and they don't interact with other family members, that is all risk factors. Knowing that other siblings are positive for genetic testing, and anticipating how is that gonna impact the relationships with other, and also the guilt of having a mutation. And there are other psychosocial factors, I'm not gonna read them all, but patients who have a history of losing someone from breast cancer, history of previous losses or trauma that put them at risk of being more vulnerable, patients with low self-esteem and low psychological functioning. And there are patients that cope by, when they're confronted with stress by avoiding and not confronting things directly. That also put them at risk of having more distress and anxiety.
I think you brought up a lot of these issues about positive genetic test results and the impacts in terms of anxiety and the family relationships that it strained. So I think we can go through. Did you want to make any comments on this slide?
Yeah, let me just go back, except I cannot read well. So there are, right now, there's possibility of having genetic testing after they're done with the treatment. But there are also genetic testing that can learn before and that will determine whether they would have prophylactic mastectomy. So with the treatment-focused genetic testing, the timeline of the genetic testing, rapid genetic testing versus testing after completion of the treatment, there was a study that showed that 72% of patients who received the results of genetic testing before surgery recommended to other high-risk breast cancer patients. And 88% of them believed that the best timing was between breast cancer diagnosis and surgery to make those decisions.
And then in terms of the prophylactic mastectomy start, I think you had brought up this as an option for patients that are finding out before surgery and the impacts on body appearance and all of these other issues. So certainly these are factors that we have to take into account and be planning discussions.
Yes, it's a very personalized decision whether or not to remove the unaffected breast at the time of surgery. In someone who's 37, otherwise in good health, and has a genetic mutation that may place them at increased risk for developing a new breast cancer in the future on the other side, I think it's perfectly reasonable to consider a contralateral prophylactic mastectomy. In someone who, let's say, is in their 70s in a similar situation, diabetic, maybe history of heart attack or stroke, I try to counsel those patients that sometimes the risk actually outweighs the benefit. You're doubling the amount of surgery that's done, you're doubling the complication rate, and really our priority here is getting the patient on to their next phase of treatment. And so in a patient like this with lymph node positive disease, she certainly will benefit probably from radiation therapy. We're going to discuss that later in the case. And if there are complications after surgery on the unaffected side, it could potentially delay the next phase in treatment. And so you really have to have a very personalized discussion about whether or not to remove the other breast. It's most often done at the same time as the initial surgery, but I have had patients where we felt that it was not safe to, double the amount of surgery and prophylactically remove the other breast, and we did it a year or two after treatment for the index lesion. And so there's different options for that. And you could also have a symmetry procedure, so that cosmetically you don't necessarily have to remove the otother breast, but you can do a mastopexy and lift on the other side, so that symmetry-wise the patient is happy.
Mm-hmm. So as a reminder, this patient is 37 years old, and she's referred to medical oncology, and we talked about some of the benefits of neoadjuvant chemotherapy, and we'll talk a bit about that further. But an issue that comes up not infrequently is interest in childbearing and fertility preservation in this very young woman. And here we learn that she is concerned about how fertility treatments could affect her breast cancer outcomes. We are going to be discussing later the positive trial. This was a really important study that was presented, but just overall in terms of the safety of fertility preservation in breast cancer. Naomi, you want to take us through some of this data?
I think historically we as a field also had some concerns about, as Dr. Mautner referred to, delays in initiation of therapy, and then also thinking specifically for our hormone receptor positive patients, we're going to give them a lot of hormonal treatments when we do fertility preservation. They're going to have very high estrogen levels during that time, and is this safe? So there have been a number of studies done to answer that question. This is just one such study. This was a Swedish case control cohort study that evaluated 425 women. They were age and location matched, as well as time period matched. So the controls were patients who had breast cancer but did not undergo fertility preservation, and then the cases were breast cancer and underwent fertility preservation. And it's no big surprise here when you look at the light green between the two, on the left, those who had fertility preservation, and on the right, those who did not, that in those who underwent fertility preservation, there were a lot more live births, almost double. Not surprising. What was kind of surprising here was that the number of deaths was actually quite a bit smaller in the fertility preservation group than in the non-fertility preservation group. Maybe there are some considerations there in terms of the healthy patient effect, that those who are, considering pregnancy or ultimately becoming pregnant are healthier in general. But I think this gives us a lot of confidence that we are not negatively impacting anyone's outcomes from breast cancer by going through with fertility preservation. So definitely want to give this patient the opportunity to do so.
So in terms of the fertility preservation for young previvors, did you want to make any comments on this slide? Or?
I wanted to make a couple of comments. Just first, maybe just to go over previvors. What is a previvor compared to survivor? A previvor is a patient that was diagnosed with a mutation, inherited cancer, but did not develop cancer yet. So the only thing that they have is the predisposition for increased cancer. So there is where we can offer this fertility preservation, because they may want to decide to have a baby without passing the inherited mutation. So there are many things that they need to decide. One thing is just to go over the in vitro fertilization, the PGT, that is the pre-implantation genetic testing, that when I talk with patients, I explain that the only thing that they do a biopsy and on those embryos just to detect whether or not they carry the mutation. And based on the patients that I've been counseling, most of the time is 60% or more of the embryos that they carry the mutation. And then they select the ones that they do not carry the mutation, they implant it, and the baby can be born without that mutation. That is very important for us as patients, because really we feel guilty that we are passing that mutation to future generations. One thing that we need to counsel our patients is the cost related to this. it costs between $20,000 to $40,000 to go through fertility treatments. But here in Miami, the other day I found out that there are some foundations that they provide interest-free loans to do this. That they provide interest-free loans for 3 years that they can be repaid without interest. So really that is the help that the patients need, to give them the option, but also to help them pay for these type of treatments because they're really very expensive. So that is something you may consider to discuss it with young previvors.
I think the issues you bring up are so important because as medical oncologists or as surgeons, when we're offering patients genetic testing and they're not getting the benefit of having some of these discussions that genetics has, you know, I had a patient just the other day who didn't have any understanding about this pre-implantation genetic procedure that can be done. The life insurance issues that you brought up, these are things that don't often get discussed unless they have appropriate genetic counseling. So really important issues. Okay, so the patient is referred for fertility preservation given her desire to have children. Neoadjuvant chemotherapy is discussed. So here is a bit of a hot topic, the use of chemotherapy in premenopausal node-positive patients. The ASCO guidelines have come down and said that there's insufficient evidence to do genomic testing routinely in these patients with an analysis because of the benefit that we saw in our exponder. And I'll ask you, Naomi, is it your practice to do genomic analyses, diagnostic assays in these patients to make decisions about chemotherapy use?
So in this sort of situation, it would not be my practice to. I'm kind of following the RxPonder data as it stands right now, and we've also heard from our surgeon that she feels that neoadjuvant chemotherapy is needed to downstage the axilla. However, I do think it's a really controversial topic right now, and I think there is data to come on this. Unfortunately, it'll be far in the future before we get that data. You know, I think in some ways it can make the patient feel more comfortable if they see on their genomic analysis that they needed chemotherapy, but I think in this case, ultimately, this patient will need neoadjuvant chemotherapy.
Yeah, so my view is that in a situation where we are considering chemotherapy because we're trying to downstage the axilla, and in that situation, she had a large tumor, there's clearly a rationale. I think that in node-positive premenopausal patients in my practice, I am still ordering a 21-gene recurrence score or a mammoprint because I do think it provides important prognostic information, especially in the situation where you're giving chemotherapy in the adjuvant situation and a patient wants to make a determination about what their benefit is and the magnitude of that benefit, which is clearly linked to what their risk is. But you brought up the RxPonder trial, so why don't we go through this?
So, as I'm sure you've seen, the RxPonder trial looked at women both premenopausal and postmenopausal that were ER positive, HER2 negative, and had 1 to 3 positive lymph nodes. And so those with a recurrence score between 0 and 25 were randomized to either chemotherapy followed by endocrine therapy or endocrine therapy alone, and they were stratified according to menopausal status as well as the level of their recurrence score and what their axillary surgery was going to be. So looking really specifically at the RxPonder results amongst the premenopausal cohort, there was an invasive disease-free survival benefit in the chemoendocrine arm versus endocrine therapy alone. And when we look at the forest plot on the right, this was preserved whether they were kind of an older premenopausal patient versus a younger premenopausal patient. But I think, again, the big question remains, the question that RxPonder really brought up is the benefit of chemotherapy one of cytotoxicity on the cancer cells, or is it one of ovarian suppression? Because if the benefit is truly in ovarian suppression, then chemotherapy is a very toxic way to achieve ovarian suppression. We have better ways to do so. Next slide. And so this is a question that has not yet been answered, and the Offset NRG-09 trial by Terry Mamunis seeks to answer this question. And the schema here looks a little different than the RxBonder trial. It's specifically for premenopausal patients, and it includes, like the RxBonder trial, N1 disease with a recurrence score of 0 to 25, but it also includes node-negative high-risk patients that either have, kind of the higher end of recurrence scores of 21 to 25, as well as those intermediate scores, but with high clinical risk. And so then these patients are randomized to chemotherapy, ovarian function suppression, and aromatase inhibitor, or just ovarian function suppression and aromatase inhibitor. So this will answer this question, but it's going to be years before we get this data. So I think in the meanwhile, it's certainly a conversation to have with patients, particularly if they're not in this situation where maybe they've got one positive lymph node and they'd be ready to go to surgery now with breast conservation, and you're kind of deciding whether or not ultimately they'll need adjuvant therapy. I think it is worthwhile to discuss with the patient that there is this kind of unanswered question. We don't know whether ovarian function suppression alone is enough. And there are some times where the patient's going to tell us, I do not want chemotherapy. And if you think that ovarian function suppression may be enough, I'm kind of willing to pursue that given a low recurrence score.
Yeah, I think it just speaks to the need to individualize treatment decisions with that woman that's in front of you, and recognizing that in our exponder there were, despite being node positive, very few patients that did receive ovarian suppression, majority receiving tamoxifen, which kind of brings up that issue that you pointed out. So here in this situation, the patient did have an oncotype. It was 36, so clearly in the high range. Neoadjuvant therapy was recommended. Again, we talked about the rationale. She decides to undergo egg harvesting and embryo creation with her partner for future implantation, and chemotherapy options are discussed. She says she wants to know if an anthracycline is quote unquote really necessary.
The ABC trials are, the best data that we have for this. It's 2 trials who had a pooled analysis that looked at, amongst those who were going to need chemotherapy, 6 cycles of TC versus our standard ACT regimen. And they did see an invasive disease-free survival benefit, which was on the order of about 2% with the anthracycline. And particularly in the subgroups that were hormone receptor negative and or lymph node positive is where the particular benefit from anthracycline came. So I think given her lymph node positivity, this qualifies her for receiving anthracycline, as well as the fact that we're going to be giving her chemotherapy in the neoadjuvant setting. And although our general paradigm is that anything that's effective in the adjuvant setting should also be effective in the neoadjuvant setting, TC really has never been evaluated in the neoadjuvant setting. It's not really a standard neoadjuvant therapy. So for a couple of different reasons, I think anthracycline is right for her.
Okay, so she receives neoadjuvant dose dense AC followed by T and has a partial clinical response in the breast and an excellent clinical response in the lymph nodes. And as you pointed out, Star, the need to repeat that breast MRI after neoadjuvant chemo, it also shows a radiographic response. So here we get into, again, when the patient comes back to you, she has been found to have a ATM mutation, and how does that impact your decision making?
Sure, so the ATM mutation is not the one that we talk most commonly about. We talk mostly about BRCA1 and BRCA2, but these other genetic mutations that are actionable have variant penetrances depending on the family history. This woman has a fairly limited family history of a maternal aunt who had breast cancer at a postmenopausal age. We don't know about her mother's history, but it appears that she herself did not have breast cancer. Now the patient has breast cancer at a premenopausal age with an ATM genetic mutation. You have to assume that her breast cancer at an early age has something to do with this mutation. And so I think that we want to consider her future risk of developing breast cancer with this mutation and what to do regarding the ATM genetic mutation if she needs or qualifies for mastectomy due to that. We know that in ATM genetic mutation carriers, they have a 2 to 5-fold higher risk of breast cancer. And on that prior graph that we saw, it looked like the risk estimate for overall lifetime risk of breast cancer was about 50% or higher. However, this patient already has her breast cancer. And so now the real question is, what is her risk of getting another breast cancer in the future? And I don't think that's very well delineated in ATM genetic mutation carriers, or at least it hasn't been shown that they're necessarily at much higher risk of getting a contralateral breast cancer in the future. When we quote risk for patients that do not have a genetic mutation, they say, you know, I had breast cancer on my left breast, who's to say it's not going to come back on the right? I will tell patients breast cancer doesn't usually travel from one breast to the other. The risk is that you could develop a new primary in the other breast. And that risk while you're on endocrine therapy is about 0.5% per year. It's not that high. But you have to look at the picture that this woman's 37. She has a lifetime of screening ahead of her with mammograms and MRIs if she doesn't remove that other breast. So I think that if she doesn't want to remove the other breast, then she's looking at high-risk screening, and that's fine as long as she's able to do that in the future. But if she does want to remove the other breast for either peace of mind, symmetry, or for avoidance of having to screen in the future, I think that's perfectly reasonable given the mutation. Other things that are specific to the ATM genetic mutation, you see cancers at a younger age. There's a higher rate of ER-positive cancers, but that's overall in breast cancer in general. Higher risk of lymph node involvement and distant metastases, so just more aggressive disease with a shorter disease-free interval. And the effect that this has on local and systemic treatment, you can see some chemoresistance. And we know, at least in BRCA mutation carriers, we've been treating with PARP inhibitors. I don't know that that's been studied in specifically ATM genetic mutation carriers. But there is some evidence that radiation itself, if there's exposure to the other breast, could increase the risk of contralateral breast cancer in the future as well. So I think in this particular patient who's premenopausal, it's perfectly reasonable to consider a contralateral prophylactic mastectomy if she chooses.
I think you bring up a really important point about quantifying the risk of developing a cancer in the other breast. I think patients sometimes become very fearful of having to go through this again and in their mind overestimate what that risk is. Of course, outside of a genetic mutation, I think that number, giving them that information, but recognizing the amount of time they have at risk to develop that is also a really important aspect of the discussion. So here the patient undergoes left mastectomy and sentinel lymph node biopsy with a 3.2 centimeter residual cancer in the breast and 1 out of 3 positive sentinel nodes. And she elects to undergo a prophylactic mastectomy on the other side. The findings were benign. So maybe you can just comment on whether the management of the axilla here.
So I don't think it goes into detail here, but if we're performing a sentinel lymph node biopsy in this patient after neoadjuvant chemotherapy, there are some very important considerations to make sure that we decrease the false negative rate of that sentinel node at the time of surgery. The first thing that we can do is if this patient had a core biopsy prior to initiating chemotherapy and a clip was placed at the time of that biopsy, you want to try to be sure to remove that clipped node. There are other nodes in that axilla that may be positive as well, but specifically that node that was originally biopsied, we know was positive. And so if you can remove that targeted node by either placing a radar on that clip or doing a specimen x-ray after removing that node to show that the clip was actually removed and you know that you got that node, that's one way to decrease the false negative rate of the sentinel lymph node biopsy. Additionally, dual tracer mapping, so using not only lymphozurin blue dye to map the lymph nodes, but radioactive technetium. So to decrease the false negative rate, you want to do dual tracer mapping on anyone that received neoadjuvant chemotherapy where you're performing a sentinel lymph node biopsy. And then lastly, ACOSOG 1071 showed that if you removed less than 3 sentinel lymph nodes at the time of sentinel lymph node biopsy, the false negative rate was going to be too high. It was going to be over 10%. However, with the addition of that third node, if you're able to identify at least 3 nodes, it drops to below 10% to about 7% with 3 sentinel nodes removed. And so whenever we're performing a sentinel lymph node biopsy on a patient like this one, the goal is number 1 to get out that clipped node and number 2 to get at least 3 sentinel nodes. I send those nodes for frozen section analysis at the time of surgery, and so I have the pathologist look under the microscope at those lymph nodes and call me and tell me whether or not they see residual cancer in those nodes. If the answer is no, then we stop right there. If the answer is yes, that there is residual cancer in those nodes, then I would proceed to perform an axillary lymph node dissection at the time of surgery. And then you get into a gray area where the answer is no within the operating room. And then on final pathology, you see a small amount of residual cancer that was actually found once they took deeper cuts into those nodes. And that's when it gets to be a little bit tricky of whether you bring the patient back to the operating room to perform that completion axillary dissection or they move on to radiation therapy. At this point in time, and we're going to go into several slides that look into trials that may be applicable to this patient, the standard of care is for that patient to undergo an axillary dissection if there is residual nodal disease, and that's because at this point in time, we have to assume that disease is chemo-resistant, and we don't know that it is safe to omit axillary dissection in those patients, but there is a trial specifically looking at that question. And there are other trials that are not necessarily specific to this type of patient, but you can kind of tease some of that data out to try to apply it to a patient like this. We really want to, the whole point of giving this patient neoadjuvant chemotherapy was try to downstage her axilla and avoid axillary dissection. So we're still trying to achieve that goal in this patient. It really depends on looking at that pathology. Is it, some isolated cells in that original node that was positive and the other two are negative, or is there really like a macromet still in that node, and that's concerning. So we can go into, I guess, her final pathology and what she ends up doing ultimately afterward.
Sure, so that's a nice segue also into bringing up radiation discussions in terms of the choice of sentinel lymph node biopsy versus axillary lymph node dissection, how that impacts radiation decisions.
Yeah, thank you, Reshma. As they say, ladies first. So I'm glad that now we got a chance to talk about radiation therapy. So yes, in radiation therapy, our primary goal is local regional disease control. We're a local modality. And in this young woman that has a positive lymph node after neoadjuvant chemotherapy, the recommendation is for having post-mastectomy radiation therapy. There is a strong recommendation that is mainly based on the fact that she had a positive lymph node after neoadjuvant chemotherapy. This data comes from data that was collected by Memunas et al., shown here in this graph. These are NSABP patients who were treated with neoadjuvant chemo and followed over 10 years. And you could see this woman falls under the blue dotted curve with a tumor that was initially T3, around 5 centimeters in size, with a positive lymph node, clinically positive initially, pathologically positive after lymph node. Her risk of recurrence is 20 to 25% without radiation therapy, just with mastectomy. So that is the reason why she is recommended treatment. Now, as for the question for axillary dissection versus axillary radiation, we have excellent data from the Amaros trial that now reported 10 years out. The caveat here is that the Amaros patients had T1, T2 tumors and did not give neoadjuvant chemotherapy. But you could see here that radiation has almost comparable results to axillary dissection in terms of disease-free survival. The curves are overlapping, which tells us that radiation is perfectly capable of controlling microscopic disease within the axilla without having to subject these young women for axillary lymph node dissection and take the risk of lymphedema. On the other hand, you could see the lymphedema risk in the Amaros trial. The risk of lymphedema went down from 24% down to 11%. So again, it's a very tough question we have at hand because this woman doesn't quite fit into the Amaros trial because she had neoadjuvant chemotherapy. I do agree the standard of care to date is axillary dissection. However, the risk of lymphedema is around 24%. Can go to the next slide. So to address this question in the setting of neoadjuvant chemotherapy, we have the Alliance 011-202 trial. These are patients T1 to T3 and one patient, so this patient would fit into this trial. They all receive neoadjuvant chemotherapy. They go to surgery. At the time of surgery, if they have a sentinel lymph node positive, then they're randomized to either having further axillary dissection and radiation therapy or abort axillary dissection and go to radiation therapy alone. So this is again asking a similar question to the Amaros trial in the setting of neoadjuvant chemotherapy. The trial completed accrual and we're hoping to see results soon. Now, I think this question from a radiation perspective would have been way more challenging if this patient had a complete pathological response in that axial lymph node. This is not expected given her molecular subtype, which is ER/PR positive, HER2 negative. Still, this subtype, we're not seeing the best pathological response to neoadjuvant chemotherapy. We need to improve there. But there are other women that have HER2 positive or even triple negative. Now we're seeing improvement in systemic therapy, where those women are getting complete pathological response in their lymph nodes. So what to do with these patients? Here we step into an area where the benefit from radiation therapy is less established. And we have a trial that completed accrual in 2020. This is the NSABP B51 trial. Those patients get neoadjuvant chemo, they go to surgery, and then if they have mastectomy and they're found to have complete pathological response, the randomization is to radiation therapy or just observation, abort radiation therapy, meaning this patient had a complete pathological response. Why are you chasing microscopic disease? You can just observe them. So this is a very exciting trial. On the other hand, if the patient had lumpectomy, the randomization here is to breast radiation therapy alone or breast and regional lymph nodes. So we're waiting for results from the B51 trial, which will help guide our management decisions if the patient has a complete pathological response. Now, one last point regarding radiation and genetic mutations. So this patient has a ATM mutation. She's a carrier. These mutations in genes like ATM and BRCA are important for our discussion because theoretically those genes are involved in DNA repair. And whenever we have a mutation in a DNA repair mechanisms, we have concerns regarding excessive radiation toxicities or the risk of second malignancies. However, if the patient is heterozygous or just a carrier of this mutation, there has been studies that those patients can be receiving radiation similar to the non-carrier, non-mutated patients in a safe manner. These have been studied and observed over a long time. However, one alert mutation is the P53 gene, or those patients that have the Li-Fraumeni syndrome. This constitutes a contraindication for radiation therapy because of the risk of second malignancy is extremely high if they get radiation, and also they've been reported to be radio-resistant as well.
Thank you for those comments. So the patient goes through radiation, and then this case just highlights that taking care of these patients is definitely a team approach, multidisciplinary care. Now she's back with the medical oncologist to discuss adjuvant endocrine therapy, and we talked about a little bit earlier about the importance of this whole concept of ovarian suppression and maybe it contributing to the benefit that we're seeing. But in this situation, what hormonal therapy would you recommend, and is there a role for adjuvant treatment with the CDK inhibitor, specifically abemaciclib?
And so the SOFT and TEXT trials really help us to answer this question. We generally talk about them kind of all together with the pooled analyses, but the SOFT trial alone is really seeking to answer for premenopausal hormone receptor positive patients whether or not the addition of ovarian function suppression to endocrine therapy had a benefit, and then the TEXT trial was assuming a benefit from ovarian function suppression and was looking to distinguish a benefit from AI versus tamoxifen, and that was kind of the same question being answered by the pooled analysis. So I didn't include here the analyses from the SOFT trial alone, but the results from the SOFT trial on its own did show a benefit in this population from ovarian function suppression. And then when we look here at the pooled analysis, we did see a disease-free survival benefit from AI plus ovarian function suppression versus tamoxifen plus ovarian function suppression on the order of about 5%. And then when we look specifically at the HER2 negative population, which was something like 85 to 90% of the patients in the trials, we see that there is an overall survival benefit as well on the order of about 2% using AI plus ovarian function suppression. And so there was actually a recent update this past month in the JCO with some of these data, and it looked at a lot of different subgroup analyses and really broke down who are the patients that benefit, because that's really the big question. If we're going to put them through ovarian function suppression, a lot of toxicity, as we all know, in terms of putting them into menopause, we want to make sure that we're giving it to the right patients. And the author's conclusions were that premenopausal women with estrogen receptor positive breast cancer should receive ovarian function suppression plus AI if they have any of the following high-risk features: either age under 35, a grade 3 tumor, or T2 or greater tumor. I think it's interesting that they don't necessarily include lymph node positivity here. Certainly in my mind, that's something that also makes me think about ovarian function suppression. But a T2 tumor is only a 2 centimeter or above tumor. Certainly this patient qualifies for ovarian function suppression based on that criteria. And the caveat here that the authors gave was that the benefit from AI plus ovarian function suppression was really driven by the HER2 negative patients. And they concluded that those with HER2 positive disease might benefit from tamoxifen plus ovarian function suppression. Again, it was a small group that were HER2 positive within this trial, so I don't know that they can make kind of final conclusions about that, but it is of interest. And then thinking about whether or not to add a CDK4/6 inhibitor, we have the monarchE trial, which looked at node-positive patients with hormone receptor positive, HER2 negative breast cancer. They included both pre- and postmenopausal, and they had 2 different cohorts. Cohort 1 had either 4 or more positive nodes, or if they had 1 to 3 positive nodes, they had to either have a grade 3 tumor or a tumor size greater than 5 centimeters. And then cohort 2, also with 1 to 3 positive lymph nodes, was on the basis of a Ki-67 greater than 20%. Patients were randomized to abemaciclib plus standard endocrine therapy versus endocrine therapy alone. And next slide, and we saw that there is an invasive disease-free survival benefit with abemaciclib, and kind of our updated data, which is really important, is that that benefit did not just last for the 2 years that they were on the adjuvant abema. It persists beyond, so it suggests that we're not just delaying recurrence with adjuvant abemaciclib, we are preventing recurrence. So certainly for this patient, on the basis of her tumor being over 5 centimeters with the 1 to 3 positive lymph nodes, she would qualify for adjuvant abemaciclib.
And then also not shown is the analysis looking specifically at patients that had received neoadjuvant chemotherapy and had residual disease, where we saw that hazard ratio, very consistent benefit here in a patient that presented like this with a large tumor.
And so last month we had an update from the FDA in terms of their expanded criteria to prescribe abemaciclib in this setting. Really what they're saying is that they are now following the inclusion criteria of the trial. Previously, if patients were in that cohort 1 where they had either grade 3 tumor or the tumor over 5 centimeters and the 1 to 3 positive lymph nodes, the FDA label had been for still having Ki-67 over 20%. And here, when they're removing that criteria, that requirement for 20% Ki-67, they're basically just saying they're going to follow the way that the trial enrolled. And you could still use the Ki-67 over 20% if that is your criteria to give abemaciclib, but if they have one of the other criteria, they no longer need that 20% Ki-67. And then another press release that we saw in this past week was that the phase 3 NATALY trial has met its primary endpoint, which is really exciting. The NATALY trial looks at adjuvant ribociclib in this same type of setting, but they used patients that were slightly lower risk, kind of a more expanded patient population than what the monarchE trial used. They also included, patients that were stage 2. They included all stage 3, but stage 2 that were either N0 with grade 2 or 3 or a Ki-67 over 20%, or stage 2 node positive. So it is a larger patient population, and we'll be looking forward to seeing some of the data at an upcoming meeting from this trial.
So now we move into other strategies that we could offer this patient to reduce her risk of recurrence, and there's been some work looking at zoledronic acid and denosumab in this setting, so maybe you can take us through some of this information.
And there have been many trials, looking at bone-modifying agents. This trial that I'm showing here is a meta-analysis that includes, I think, something like almost 20,000 patients, but is looking at using bisphosphonates versus just doing your standard endocrine therapy, and the risk of not only skeletal-related events, but also bone recurrence, and they do see small benefits in terms of bone recurrence. I usually tell patients this number is not huge, but it is real, and then on top of that, we're thinking about giving this premenopausal woman ovarian function suppression and AI. She's got then a lot of years of kind of being postmenopausal now, earlier than would have otherwise happened, and so there can be big impacts on bone over time. So I think she is a particularly good candidate for a bone-modifying agent. In my practice, I tend to offer this to anybody who had received or was a candidate for prior chemotherapy, and then offer this in the adjuvant setting, or anyone who has kind of that borderline bone density that's almost osteoporosis. The recommendation in the ASCO guidelines in the NCCN is for postmenopausal women, either natural or induced, who were candidates for systemic therapy, which I think is kind of interesting wording. I think in some ways they kind of leave it up to us, even if patients didn't receive chemotherapy, but they're on endocrine therapy and you think that they're high risk, that this could still be an option.
And I think you bring up a good point about treatment fatigue. As we keep piling on a lot of these therapies, we know that patients do have a lot of side effects from these drugs, and they're worried about potential other side effects like ONJ and issues like that. So here, in terms of the case, as far as adjuvant therapy, she is offered letrozole, ovarian suppression, abemaciclib, zoledronic acid, and has, as is to be expected, some side effects that are detailed here. She discusses that she wants to come off endocrine therapy in an attempt to conceive. So what can be offered for management of treatment-related toxicities? Forgive me, I'm not sure whose slides these were. I jumped in, so.
We all probably spend a lot of time in our clinics managing and talking about these toxicities. And so there's a number of different strategies that we can use. This is just looking at pharmacologic treatments for hot flashes, but you see here paroxetine, venlafaxine, gabapentin, pregabalin. All the green bars are the treatment arms, and then the white bars are the control arms. And you're seeing, the higher the bar is, the more reduction in symptoms they have. So kind of interestingly here, even the placebo did pretty well at reducing their hot flashes, but some of these other treatments did even better. And so, I tend to, if they already have issues with neuropathy, then, I'd be looking more at using gabapentin. If they're having more issues kind of with depression or mood, I'd be thinking more about using an antidepressant. But a lot of patients tell me, I am already on so many pills, the last thing I want is another pill. So we can go to the next slide. Acupuncture actually has some data as well for vasomotor symptoms, and I think a lot of my patients feel relieved when I'm recommending something that's not a pill. So acupuncture certainly can help with vasomotor symptoms, every bit as much as pharmacologic therapy, and it can also help with the arthralgias from AI. I think that this trial is kind of interestingly designed, that they've got two different control groups for the acupuncture. One is the waitlist control, and one is sham acupuncture, where they're basically just kind of putting needles wherever. And sham acupuncture was actually better than waitlist control, which I do find interesting, but true acupuncture helped the most in a number of different areas in terms of pain. So I think acupuncture is a nice thing to be able to recommend for our patients.
Very operator dependent. I think that's the real challenge, and of course, insurance doesn't always cover it. You have to go for many weeks, multiple times a week, so I think this is a great strategy, but the implementation of it practically sometimes can be challenging.
It makes me wonder if the placebo effect is also something really in play here, because I at least personally don't see so much issues with AI in the metastatic setting. Whereas in the adjuvant setting, it tends to be a big issue for patients.
Well, I think also the goal of therapy there in the metastatic setting, when women develop an incurable illness, they seem to be, more tolerant of side effects because the indications are different. So here it just kind of points out some of the issues that we've talked about.
I want to make a comment about medications, especially specifically antidepressants like venlafaxine is a serotonin or epinephrine reuptake inhibitor. It helps with hot flashes, but also can help with musculoskeletal pain. So it's very similar as duloxetine, but in breast cancer patients, we try to stay away from medications that inhibit the 2D6 enzyme because it can interact with medications like tamoxifen. So prescribing like an antidepressant like duloxetine can decrease the efficacy of tamoxifen, but this venlafaxine is a good option and can help with the arthralgias caused by the aromatase inhibitors and hormonal therapy. And this patient went through treatment, had surgery, and it's very, very important to talk to her about body image. Researchers developed like a framework for conversations for providers. So they mentioned the 3 C's. The first one is to tell the patient that it's very common and normal for cancer patients to experience body image difficulties. The one is inquiring in an open-ended manner about the nature and concerns they have about having body image changes, and exploring the consequences of impact of body image difficulties and to their day-to-day functioning, even when they're getting dressed, when they interact with their husbands. So those questions are extremely important. So it is important to encourage patients to provide a description of which body parts are being affected and how the body has changed, along whether these changes were expected or unexpected. Ascertain the importance and meaning of the changes of their body part. Everybody is different. Additional time should be given to patients to talk about the degree of preoccupation and distress with body image changes. If they avoid activities because of their body change, reassurance-seeking behaviors related to body change, and specific concerns about sexuality and intimacy. One of my patients, I remember, she wanted to have a reconstruction surgery, but the family and the husband did not. There was an issue at the house because they said, oh, it's another surgery, you're gonna be sick, there's a lot of risks. So it's important to evaluate the importance, what the meaning of the body changes for the patients is in the relationship with the family. About 81% survivor patients do not talk about sexuality of survivors. They never discuss that conversation. So it's important to learn what the side effects, for patients to know what the side effects are. So women undergoing mastectomy for breast cancer not only deal with the loss of a sexual organ, but they also experience loss of sensation in the surgical area, plus the addition with the altered body image change. Breast and pelvic surgery with lymph node dissection resulting in lymphedema, and that can also has an impact on sexuality and body image change. Chemotherapy side effects, symptoms of fatigue, changes in mucosal lining, side effects, nausea, vomiting, that is going to interfere with the desire of having sex with the partner. And breast cancer patients, that husbands, spouses, feel that you don't love me anymore, or why are you changing, and it has to do with a lot of side effects from the treatment. Some chemotherapy can cause in hair loss and contribute to feelings of sexual unattractiveness. Patients are wearing a wig and they don't feel, so they're more inhibited, they don't interact well with their husbands or spouses. Changes in hormonal levels, induction premature menopause and vaginal atrophy can interfere with sexual response and can be long, late-term effects of chemotherapy treatment. So what are the interventions? There are different therapies, cognitive behavioral therapy for sexual side effects. It helps with education, coping strategies, problem solving, and methods to address cognitions, emergence of schema, and changes in the self. So with therapy, patients can have cognitive distortions and altered self-body image, and with therapy, working with them and working on those cognitive distortions can help patients to feel better and do promote behavioral changes to feel better and cope better with long-term cancer. There's also psychosexual therapy and expressive, supportive, educational, sensei focus. So there are many therapies, and it's important to find sexual therapists or psychotherapists in the community who are familiar with treating patients with cancer. And there's also mindfulness programs for relaxation that could be promoted. So sex therapy provides information, support, and guidance. There are practical strategies for communication. There are treatments into sexual relationship, identification of different ways of having sex. It's important to promote intimacy with couples, even though patients is not up to having sex because of pain, but there are other ways to become intimate and close to the partner, and sexual therapy can address that. As she mentioned before, it's important to address symptoms of menopausal with medications and their interventions to help patients go better.
Thank you so much. So we touched briefly earlier on the whole issue of fertility treatments and the safety, and you took us through some data, and I alluded to the positive trial. This is a young woman. She is desiring pregnancy. She's been on endocrine therapy, is having some side effects, and comes to talk to you and asks if pregnancy is even safe after a diagnosis of a hormonally driven breast cancer. So Naomi, you can talk to us about that.
So we had some exciting data from San Antonio this year that from the positive trial looking at pregnancy after breast cancer. The patients enrolled were stage 1 to 3 hormone receptor positive breast cancer. And basically after they had been on somewhere between 18 to 30 months of endocrine therapy, they were allowed to come off. They had a 3-month washout, and then they were given a up to 2 years break in order to conceive, deliver, and breastfeed if desired. And then after that time, they went back on endocrine therapy to complete whatever endocrine therapy course they would have otherwise been on. And the results were really exciting. This was a single-arm trial, so they used data from the soft and text trial kind of here as a comparator. So you see on the left the breast cancer-free interval. The brown line are those in the positive trial, and the dotted line are kind of historical data from soft and text. And we did see a better breast cancer-free interval, less events in the positive trial. Really, the positive trial was just looking to see that they didn't have more events than historical controls, and they did not. They actually had close to half of what their threshold was to stop the trial. And also in terms of distance recurrence-free interval. So it does look that in general, for patients with hormone receptor positive breast cancer, if they really desire pregnancy, it's safe to come off their endocrine therapy and then go back on. But a caveat here is that 93% of the patients on this trial were stage 1 or 2. You know, our patient is stage 3, and so I don't think we necessarily have great data for patients who are stage 3, but if she really desires pregnancy, I think that's a conversation that needs to be had, and ultimately would support her moving forward with pregnancy with that kind of caveat.
Yeah, and I think the other important point to just highlight is the need for longer term follow-up, right? Because we know that hormone receptor positive breast cancers tend to recur later or can recur later. In fact, 50% of the recurrences that happen after 5 years. So understanding that this woman's risk is kind of for much longer than 5 years, and it becomes really complicated to have these discussions about bringing a child into the world and having the risk of having a metastatic recurrence, and is there someone else that will be there in the family? So these are the aspects that become really tough, and of course we rely on our colleagues, our psychologists, psychiatrists, the rest of the team to also come together and help our patients, especially our younger ones, make these tough decisions.
And that there's not a lot of time really to make this decision,
Sure.
you know, because she was 37 at initial diagnosis. You know, now we're probably looking at a 39-year-old, and if she wants to get pregnant, time is kind of the essence.
I've had patients also that have taken the route of using a surrogate. And so this patient made embryos between her and her husband, and so biologically it's going to be their child, but if they feel that it's either not safe to go off of endocrine therapy or she's going to have a difficult time conceiving given her age now, she can use a surrogate to carry that child, and it is a very expensive process, but for patients that can afford it, it's definitely a viable option. And in this particular trial, did they break it down into how many patients got pregnant naturally versus those that needed to use IVF with those embryos?
I didn't see that data, but I'm sure they have a lot of that information that may be reported at a later time. In the absence of the pregnancy issue, how long should she take anti-estrogen therapy? This is a question that comes up quite a bit, especially in patients that are having side effects. They kind of want to see the end of their treatment plan. And how are you having those conversations, and what information are you using to make that decision?
I think with this patient, given the large tumor, the 3 positive lymph nodes, I think she's got a number of high-risk criteria, and in her case, I would just go ahead and recommend 10 years of endocrine therapy. The NCCN guidelines support that. They suggest consideration of extended endocrine therapy in lymph node positivity. But for some of the lower risk patients where, we're getting to year 4, they're really tolerating their endocrine therapy fine. Sometimes they have some concerns about coming off because they've gotten used to taking this pill every day and they're worried about just stopping it. The breast cancer index can be very helpful. There's a number of trials here that have looked at various strategies of extending endocrine therapy, and the breast cancer index has kind of been retrospectively validated in a lot of those trials that when it predicts a benefit from extended endocrine therapy, it held out in a number of these trials. So for somebody who doesn't have a clear-cut indication for extended endocrine therapy and they are willing to entertain the idea of extending to 10 years, I tend to use the breast cancer index.
So I'll just add that in my practice, I've been using BCI even in patients with node-positive disease because there is data where it has been validated in patients with up to 3 positive nodes. An important caveat here with regards to our patient is she received neoadjuvant therapy, right? And the data sets that are shown here where BCI was validated didn't really include patients that had received neoadjuvant therapy, so I'm not routinely using it in that situation, and certainly in a patient like this, I would consider extending in the absence of any genomic assay. Okay, so here's a summary of the case. I'm so happy to see that we're on time. When I saw all these slides, I was a little worried that we wouldn't make it through everything. I will tell you that our intention was to actually go from the adjuvant setting to the metastatic setting, but as you can see, there are so many exciting data sets that we wanted to go through, so much important information in the early stage setting that we did not engineer this case for this patient to become metastatic, but it's kind of a nice segue into my talk on novel therapies in ER-positive, HER2-negative disease in the metastatic setting, which will come next. So here we have a 37-year-old premenopausal woman. She presented with a clinical T3N1 ER-positive, HER2-negative breast cancer. She received neoadjuvant therapy with an anthracycline taxane and had a good clinical response, but there was residual disease. She was offered post-mastectomy, adjuvant radiation, OFS and AI, adjuvant abema, and a bone-modifying agent, and was offered evidence-based multidisciplinary approaches to manage treatment-related side effects and their psychological impact of diagnosis and management. So we are right on time. If anyone has a burning question or comment about this case, I'd encourage you to raise your hand.
Just an update. Florida did pass a law in July 2020, Law 1189. It amends the state insurance law pertaining to the use of genetic information. It prohibits life, long-term care, or disability income insurers from canceling, limiting, or denying coverage.
That is only in Florida because the rest of the country doesn't have that. Only Florida. We are very lucky.
That's great. Thank you for sharing that.
Yeah, thank you for
Oh,
sharing
that's
that
wonderful.
because it's new, but we want to replicate that in the other states. Thank you.
That's an important comment. Thank you.
Yeah.
Anyone else? Okay, so we'll save some further discussions at the end. So now, someone was supposed to introduce me, but I'm still here. So we'll move into my talk. You all are welcome to stay seated or find a seat, whatever you're comfortable with, our panelists on the stage. Okay, I'll stand for this part. Okay, so now we're